Hola, muy buenos días. Muy buenos días al doctor Vargalló. Muy buenos días a todos los que se han unido el día de hoy con nosotros en esta masterclass. El día de hoy tenemos al doctor Peter Beitsch. Él nos hablará sobre la perspectiva y el uso de las pruebas genéticas desde el punto de vista clínico, desde el punto de vista más del área quirúrgica, y esto es de gran interés para todos nosotros. El doctor Beitsch obtuvo la licenciatura en medicina en la Universidad de Texas Southwestern. Se especializó en cirugía oncológica en el Anderson. Actualmente es el director del Dallas Breast Cancer y presidente del grupo quirúrgico de Dallas, y es expresidente de la American Society of Breast Surgeons. Es miembro de las asociaciones como la Asociación del MD Anderson, la Sociedad de Oncología Quirúrgica John Wayne, el Colegio Americano de Cirujanos. Cuenta con más de 100 publicaciones y su línea de investigación se encuentra en el campo de la cirugía de mama y cáncer de mama. El doctor Enrique Vargalló, ya lo conocen todos ustedes. Él es cirujano oncólogo. Él es el jefe de tumores mamarios del Instituto Nacional de Cancerología y estará el día de hoy junto conmigo coordinando esta sesión. Doctor Vargalló.
Gracias, doctor Cantú. La realidad es de que la idea de traer una masterclass, gran idea para este curso, pero de pronto, queremos poner los conocimientos lo más pronto posible en nuestro actuar diario, ¿no? Y me parece que el doctor Peter Beitsch es uno de los que hacen que las cosas sucedan. Les voy a dar un dato más allá del currículum que el doctor Cantú mostró. El doctor Peter Beitsch colaboró hombro con el doctor Armando Giuliano en este artículo tan controvertido hace algunos años como el Z11, y entonces finalmente es alguien que, a pesar de las condiciones, termina por concretar una idea. Entonces, thank you so much, Peter, for being here, for share with us the perspective view of how we use the genetics today, more than for consular genetics for the ones that are in front of the patient. So thank you so much, Peter. He's a very close friend, and I'm very glad to have you here.
Enrique, thank you so much for those kind words. Welcome, and buenos dias from Dallas. Let me get rolling on the talk today. So we're going to go over a little bit about, I want to level set everybody on genetics. Then we're going to talk a bit about who should be tested. And then probably the most important thing you're going to hear today is how to manage the pathogenic variants or the mutations that are found. And then I'm going to talk about the future. So this may be redundant for a lot of people, but I just wanted everybody on the same page. So every cell in our body has 23 pairs of chromosomes. If you're a male, you have one Y chromosome, and if you're a woman, you have two X chromosomes. You get one set from each parent. It's about 3 billion base pairs. Interestingly enough, only about 2% of all the DNA in your cells, in your nucleus, is actually transcribed into messenger RNA. Messenger RNA then goes on, is translated into proteins, and that's how the cell functions. The exome, or the exon DNA, is about 20,000 gene pairs. So you have 20,000 genes from each parent that are translated into proteins. 98% is non-coding DNA. This includes introns, which are the pieces in between the exons that are transcribed into messenger RNA, a bunch of pseudogenes, and regulatory segments on the front end and back end of the genes. Base pairs, there's AT and GC. There are, and this is actually quite was revelation to me anyway. There are minor variations in all of our DNA in about 1%. One in every 100 base pairs has a minor variation. Most of they're called single nucleotide polymorphisms. The vast majority are not harmful. Some are actually beneficial, and that's how evolution occurs. And some we don't know. Some are called variants of unknown significance, or VUS. That's going to pop back up later in the talk also. But there are variants that are pathogenic or called mutations. And typically, they cause a loss of protein function by truncating it, or you have an amino acid substitution that alters the protein function. And the pathogenic mutations really fall into 4 broad categories. Point mutations, where you're just switching one base pair for another base pair, and that causes a shift, causes a change in how the messenger RNA and ultimately the protein is made. You can insert or delete small 1 or 2 base pairs. That shift changes the DNA reading so that it often leads to a truncation or a stopping of the protein before it's actually made the functional protein. You can get big pieces within the gene that are rearranged. That's the so-called BART mutations that we now report on. You can lose an entire gene. That's called loss of heterozygosity. Generally, the effect of the mutation on the corresponding RNA and or protein causes a complete absence of the protein, or you get a truncation, a small protein that doesn't function, or it causes a convolutional change in the protein so it doesn't function properly, only functions a little bit or doesn't function at all. Most pathogenic mutations lead to a loss, partial or complete loss of function. And that's how you get hereditary cancers. You're born with a germline mutation. It generally doesn't manifest for a little while, but as all our DNA gets replicated and used during cellular activities, you can get a second mutation in that gene, and then that will lead to a tumor. So typically, if you have a germline mutation, you get earlier cancers and more cancers, and these are inheritable. Of course, not all cancer is hereditary. Speculation is that about 10 to 15% is hereditary. There's probably another 5 to 15% that is, certainly we see it throughout the family members, but we haven't identified the mutations yet. And it may not be a specific mutation for that family. It may be a group of mutations or something. We don't know yet. But then a lot of cancers are just sporadic. You get a bad luck combination of mutations and end up with a cancer. So all non-hereditary cancers do have a genetic component. In fact, it's usually the same genes that are mutated. It's just you're not born with one of the mutations. You develop a mutation at some point in life, and then you get a second hit, and then that leads to the tumor development. So these are called somatic mutations. They're not inheritable. They're not in your germline, but these are the same genes that you see as in hereditary cancer. You can get a BRCA1 mutation in 2 normal genes that ultimately leads to a breast cancer. That does have implications for treatment. There's probably at least 30 genes that we know of right now that are associated with breast cancer. The 2 biggest are BRCA1 and 2. That's the green and purple down here. This was a study from about 5-6 years ago now, and it was about 60% back then. Now it's probably 50% of all mutations leading to breast cancer, maybe 45%. So there's a host of other genes. Other common genes you may have heard of, there's ATM and CHEK2 and PALB2, but there's a lot of other genes that are associated with it. This little cluster of MLH and MSH2 and MSH6 and PMS2, those are all Lynch genes, thought to be only related to colorectal cancer. Well, as you'll see, when you derange the machinery of a cell, it can lead to all sorts of cancers, including breast cancer. So many of the breast cancer related genes are actually the DNA repair genes. And this is normal cellular function. You have to unwind the DNA. You have to replicate, get the exons together and then make a piece of RNA. So it changes the DNA, and you've got to make sure that it gets back together in its normal pattern. And that's just a DNA repair that occurs normally during cellular function. But if you lose this repair mechanism, your DNA doesn't go back to normal. That DNA is screwed up and then often leads to multiple mutations and a cancer down the road. That same DNA screw up can occur when the cells are dividing. That's replicate. That's when the cells are replicating. These are all the Lynch genes, thought to be colorectal. As stated, they're not. They do cause colorectal cancer, but also a lot of other cancers, including breast cancer. So you screw up DNA repair, you're going to lead to cancers. Going to tell you a little bit about the history of breast cancer genetic testing. This is Mary Claire King. She identified the BRCA1 gene in 1994 at the University of California at Berkeley. 2 years later, she found BRCA2. She hasn't won the Nobel Prize yet. She's still alive. She should win it at some point for sure. So she identified those genes in 94 and 96, but the technique to actually sequence the genes was incredibly difficult. It was called Sanger sequencing, and basically you built the gene one base pair at a time. It took a long time to do it. Very expensive, very labor intensive. About that time, the University of California at Berkeley licensed those two genes to Myriad. And so Myriad was the only one doing genetic testing in the US for BRCA1 and 2 up until a little bit later. So the Human Genome Project, that was a massive undertaking, a several billion-dollar project. But what it did is it sequenced the entire human genome. Interestingly enough, the first person whose genes were sequenced was James Watson, who was one of the co-discoverers of the double helix of DNA. The biggest revolution, though, in genetic testing occurred in 2009 when we went from Sanger sequencing, this laborious process of building the gene base pair by base pair, to next-gen sequencing. And that logarithmically sped up the ability to sequence genes, and that is the revolution that occurred in genetic testing. The next big thing was the U.S. Supreme Court in 2013 said that genes aren't patentable. That led to numerous companies getting into the breast cancer and other cancer testing space. So that really opened the floodgates for genetic testing. And that was only 7 years ago. So we've been doing it for 7 years. We must be getting pretty good at it. Well, it's horrible, really. There's at least 1.1 million unaffected carriers over age 25 in the U.S. Less than 10% have been identified. That's a real problem. I mean, these are patients that have a potential ticking time bomb for breast and ovarian cancer, and we haven't identified them yet. It's really criminal almost, but this is the real crime. There are 55,000 breast cancer patients. They've already had a breast cancer and they have a known BRCA1 or 2 mutation. We haven't found them. We found fewer than 1/3 of those patients. 2/3 of those patients still haven't been genetically tested, still haven't figured out that, they need their ovaries out. We need to screen them for other cancers. We need to test their siblings and their children and maybe their parents to prevent cancer in their siblings, parents, and children. So that really was quite eye-opening to me. So should all women with breast cancer be offered genetic testing? If you ask the NCCN from the get-go 25 years ago, they've tried to put up guidelines for who should and shouldn't be tested. That kind of makes sense if your test costs $6,000 and you're only testing for 2 genes. It's not economically viable to test everybody with breast cancer, or certainly not everybody in Mexico and Latin America and US. That's just not feasible. Well, with next-gen sequencing, the cost of testing has dropped markedly. The NCCN has responded over the years by increasing the testing of the guidelines for testing, but it is still, as I'll show in a bit, impossible to sort out, at least for me. So to answer this question, should all women be offered genetic testing? In 2017, we really wanted to evaluate whether the NCCN criteria could actually identify breast cancer patients who had mutations and those who wouldn't have mutations and didn't need testing. So at 17 centers across the U.S., both in private and academic settings, we developed a registry where all breast cancer patients could be genetically tested, whether they met NCCN criteria or did not meet NCCN criteria. These were newly diagnosed, but also patients that had been previously diagnosed but never tested. It was an 80-gene panel by Invitae. We actually talked to every genetic testing company, and the only company that bid on it was Invitae. So God bless them. We ended up in 1 year putting in almost 1,000 patients into this trial. So it ended up about 50% of the patients met NCCN criteria and 50% did not meet NCCN criteria, that's what we were hoping for. And shockingly, there was no statistically significant difference between the two groups, whether you met NCCN criteria, which is on the left, or you didn't meet NCCN criteria, which is on the right in yellow. There is slightly more patients that met criteria that did have genetic mutations, not statistically significantly important. Interestingly enough, the NCCN criteria has always kind of been designed to pick out BRCA1 and 2 mutations. So it makes sense that there's more BRCA1 and 2 mutation patients in the ones that met criteria. PALB2 sort of is an integral part of the DNA repair mechanism that BRCA1 and 2 are involved with. So they also have a marked increase in the NCCN criteria group. But we had PALB2 patients, we had BRCA2 patients, we had big bad ATM, CHEK2, the RAD group. We had a bunch of different genes that in the patients who did not meet NCCN criteria. And these are actionable, not only for the patient, but also for their siblings, for their children. So this is the paper. It was published not even 3 years ago in the Journal of Clinical Oncology. And our conclusions really were that nearly half of all the patients with a pathogenic variant were not picked up by the current NCCN testing guidelines. And so we came to the conclusion that all patients with breast cancer should be offered genetic testing. The American Society of Breast Surgeons, a friend of mine was president at the time. He commissioned a working group, and they revamped their guidelines on genetic testing for hereditary breast cancer to say that all patients with breast cancer should be offered genetic testing. Very controversial at the time, still somewhat controversial at the time. And since it is a Society of Breast Surgeons, they also stated that surgeons can and should order genetic testing. Is it cost effective? Well, the British looked at it within the United Kingdom. They were offering a multi-gene testing panel, and they thought that over 2,000 cases of breast and ovarian cancer could be prevented by offering breast cancer patients genetic testing. So you're preventing it in their family members, their children, and it could actually save over 600 deaths. And that's even higher in the U.S. Almost 10,000 cases could be prevented and 2,400 deaths in the U.S. So it is absolutely economically viable to offer and should be, in my opinion, all breast cancer patients should be offered and should receive genetic testing, not just for them, but for their siblings and for their children and maybe their parents too. So what about everybody that doesn't have cancer? What about all the rest? Well, there are simple follow guidelines. You just got to look at this every time you see a patient. This is the crazy NCCN guidelines that insurance companies in the U.S. adhere to, but it is indecipherable in most clinical practices. So a company that I'm peripherally affiliated with called MedNeon developed a phone app that can help people decide whether the patient they're seeing in their office that day qualifies for genetic testing or not. These are unaffected patients. They do not have breast cancer at the moment. So it can give you a guide whether they fit the NCCN criteria or not. And it also gives you a risk assessment on those patients, a Tyrer-Cuzick version 8. So it's that blue button in the upper left-hand corner. The next screen, you plug in some data, their gender, their age. You plug in some more data on the patient. And on the far right, it kicks out whether they meet NCCN criteria. There's a thumbs up, or the ASBS criteria with a thumbs up. It can print you a letter of medical necessity, which is something you need in the U.S., and hopefully lead to more genetic testing, more uptake of genetic testing. So what is the biggest roadblock? One is identifying the patients. We now have a phone app that's relatively easy to use. That is distributed by Invitae throughout Latin America, I'm pretty sure. So something to look into. So is really the biggest roadblock cost? Well, the price for a full cancer panel, somewhere between 30 and 84 genes, depending on what company, has fallen to $250. It used to cost around $5,000 to do the test when it was Sanger sequencing, when you had to put a base pair on and on and on. Now it's fallen with next-gen sequencing to $250. So that's pretty hard to beat that price. So what is the biggest roadblock? It's not knowing what to do with the results. A lot of primary care, a lot of breast surgeons, for that matter, don't know enough about genetic testing to know when they get a mutation what to do with it, so they don't order the test. Well, management guidelines are critical to increase testing. That is, in my opinion, the biggest roadblock. So how do you manage these? Well, negative test is pretty easy, right? You don't have to do anything genetic. They have no genetic mutations. You don't have to worry about it. But they're getting tested for a reason. They generally have a family history of breast cancer, or they're at an increased risk. And so you still have to manage their breast cancer risk, even though they don't have a genetic mutation. And you can do that either with the Gale model or the Tyrer-Cuzick risk. I use version 8. It's widely available. It's free online. I use that to base the risk of my patients and how much follow-up and imaging and clinical visits that they need. There's the Gale model. It's still in use widely. I don't use it, but I know a lot of people do. It'll give you a 5-year and a lifetime risk estimate of that patient's breast cancer based on a little bit of family history and also some the age and whether they've had biopsies and whatnot. But I think a much better risk assessment tool is Tyrer-Cuzick. This is version 8. It asks you a whole bunch of questions, and including height and weight, which gets you a BMI on the patient, their menopausal status, if they've had biopsies, but even if they've had something that's not included in Gale, which is just hyperplasia, that does increase your risk. The biggest thing that's changed with version 8, though, is with density. Mammographic density was added from version 7 to version 8, and I'll show you in a minute. The density change on your mammogram can cause a 4-fold increase in your breast cancer risk from fatty to dense. There's a bunch of ways to assess it. Most radiologists in the U.S. just use the BI-RADS density, which is really they sort of eyeball it. Volpara, and there are other companies now that will give you an actual computer-generated density score, which is probably a better way to do it. It should be age-adjusted and BMI adjusted. So you can have a young, healthy marathon runner with a very low BMI, but she has no fat in her breast, so she has very dense breasts. So you do need to adjust it for BMI, and the Tyrer-Cuzick model allows that. Version 9 is going to include alcohol consumption and exercise, and also SNPs, which are single nucleotide polymorphisms. I'm going to talk more about that shortly. So here's just the effective density on the risk with no family history in that column, and with a mother with breast cancer early in life. But if you have no family history, a fatty replaced breast, 5% risk, when you're sort of the baseline known risk is 11 or 12%. But if it's extremely dense, it's 4 times greater, 16%. And if you throw a family history in, you can double all those numbers. So density by itself is a very important risk factor in breast cancer risk, and then also it screws up your mammography, because in very dense or heterogeneously dense, it can hide cancer. So density is a big issue. Here's hyperplasia. I just wanted to point out hyperplasia here. not included in the Gale model. We know that if you have LCIS or atypical hyperplasia, you're at high risk of breast cancer at some point down the road. But even just hyperplasia itself increases your risk from sort of baseline of 12%, increases at 50% to almost 19%. So, and then one of the few factors that can be controlled, although not particularly well, is whether you have children or not. If you don't have children, your risk is going to be about double the population of the women who do have children. So interestingly enough, let me talk a little bit about, this is still within the patients that do not have a mutation, a pathogenic variant. The risk score will be polygenic risk score, which was developed by Myriad. It's 86 SNPs, or single nucleotide polymorphisms. These are not cancer genes. They are maybe related to some of the cellular upkeep of the cell, but various patterns within the SNPs lead to either an increased risk or a decreased risk. Right now, this is all based on white European ancestry, but it's coming for other ancestries. And so be on the lookout for the polygenic risk score for other ancestries. Here's just the paper that explains it. And if you just look, the curves are the various polygenic risk scores, and you can see how it modifies your risk. If you have no family history, your risk can be below average or 4 times the graded for the highest risk, the highest polygenic risk score. And the same goes with women with a family history of breast cancer. The curves spread out even more. So polygenic risk score, I love. It's usually included with clinical factors. And when you get it back from Myriad, it includes Tyrer-Cuzick version 8, and then the modified polygenic risk score with Tyrer-Cuzick. So I really like this for patients that test negative for mutations to help guide me in their management of their breast cancer risk with additional imaging and additional follow-up clinical visits. So what about the variant of unknown significance? Again, these are small, little, generally single nucleotide polymorphisms, little minor variations in the gene, but we don't know whether that minor variation causes a pathogenic variant, causes a bad mutation, or they don't. But 98% of the time, these end up being benign. So when you get a VUS, and you will get VUSs on genetic testing. In fact, in our Universal Breast Cancer Registry, half of the patients had a VUS. You ignore the VUSs. That is essentially a negative test. 98+% turn out to be benign. They're just these minor variations. You don't need to worry about it. And you manage all of these patients based on Gale model, if that's your thing, or Tyrer-Cuzick risk, or, I think the best way to manage them is with the polygenic risk score with Tyrer-Cuzick layered on top of it. But what about pathogenic variants? I think that's probably what we're all worried about the most, and that's what probably prevents a lot of genetic testing, because we don't know what to do with these patients once we get them. Well, I'll tell you what to do with them. It's not that hard, and actually we'll give you a tool that will even help more. So pathogenic variants or mutations vary by age of onset of the cancer. We're talking mainly about breast cancer today, but other cancers, whether they penetrance, which is the percent of people with that mutation that end up with a breast cancer. Even BRCA1 and 2 patients don't have 100% risk of developing a breast cancer. The other genetic milieu that they were born with modifies that, and sometimes it even prevents them from developing a cancer. Polygenic risk scores, not only do they adjust your risk when you don't have a mutation, they actually adjust your risk of penetrance when you do have a genetic mutation. I'm going to show you that data here in a minute. And the ranges for that are remarkable. And then not only do we have to worry about breast cancer in some genes, in many genes, but there's associated cancers beyond breast cancer that you need to worry about. And as we are getting better and better at curing or fixing their first breast cancer, we need to worry about those other cancers. We can't ignore the rest of the body. These aren't breast cancer patients. They are they are patients who've had a breast cancer and maybe at risk of other cancers. So be thinking about the other associated cancers. Here's just a little bit about age of onset. This is on the left, BRCA1, ovarian cancer risk. Their risk really sort of starts taking off at about age 40. That does allow them plenty of time to reproduce if that's what they want to do. And on the right is BRCA2 ovarian cancer risk. It doesn't really start taking off really till after 50, really mid 50s is when it starts taking off. So they have a much longer window to allow them to make their reproductive decisions. Age of onset varies widely between genes. And penetrance of the mutation to form a cancer. This is risk of breast cancer for the various genes. This is normal population. This is which is about 12 or 13%, somewhere in that range. 20% is where we start getting, or at least I start getting, breast MRIs on everybody every year. So all of the genetic mutations are above that. Down at the bottom, the bad actors, P10, almost 100% risk of getting a breast cancer. BRCA1, 2, and TP53 or P53 is the protein, all carry a greater than 60% risk, lifetime risk, or at least up to age 85 of developing a breast cancer. And then it goes down from there. But these are still the ones we worry about: CDH1, PALB2. I'm going to talk about all of these individually. But the penetrance varies greatly. It's not you have a mutation and you're going to get a cancer. That's not correct. So now, again, we're going to talk a little bit about bringing in the polygenic risk score. So those 86 single nucleotide polymorphisms, how they affect people with an actual mutation of a cancer-forming gene. And here's a list of the cancers. This is the paper. These are just a few here's just 5 genes that they've looked at the moment. ATM carries risk of about up to age 80 of about 28%. But depending on the polygenic risk score, this can go down to population risk, 12.9%, or it can go up to almost 60%, where we're looking at BRCA1 and 2 sort of general risk, right? Even BRCA1 and 2 can be modified by the polygenic risk score. They still carry a very high risk. Even by lowering it, it's still over 50%, and it goes up to almost 100% based on those polygenic risk scores. But the biggest variation is by far is in CHEK2. A low general risk. So if you don't modify it by the polygenic risk score, it's around just over 20%. We don't recommend prophylactic mastectomies in this group. We do recommend MRI in this group. But when you add in the polygenic risk score, it can drop to half of the population risk. Or if your polygenic risk score increases, it can go up to 70%, higher than sort of baseline BRCA1 and 2 risk. So polygenic risk score, be on the lookout. It's a modifier of pathogenic variants or mutations. It's going to become critically important. Again, these are only in white Europeans at the moment, but ancestry-based polygenic risk scores are coming. So we're going to have this on all patients. It's getting more confusing, perhaps, but don't worry, we got a way around that, which I'll tell you about in a minute. Let me just show you how this CHEK2 can sort of affect a family. This is the upper right is the breast cancer patient that came in, got genetically tested, was found to have a CHEK2 mutation. Well, she already has a cancer, so that's 100% having a cancer. But she had 4 children, 3 daughters and a son. The far left, she had a CHEK2 mutation, but her PRS score dropped her risk to 26%. The far right, this daughter did not have a CHEK2 mutation, but you added in her polygenic risk score, 25% risk. Same as her sister who had a mutation, but her sister's score was lower. Her sister without a mutation, her score was higher, was raised to 25%. So polygenic risk score affects both mutation patients and non-mutation patients, and can vary from sibling to sibling. So we've been talking about breast cancer risk, but the genes cause disruption of the machinery of cellular growth and regulation such that other cancers can be formed. ATM, of course, increases breast cancer risk, but also gastric cancer, colorectal cancer, pancreas cancer, BRCA2, the classic one for breast cancer, of course, but also increases ovarian cancer risk. We know a lot about that, but also pancreatic cancer risk. And half of what I do is melanoma, and it increases your melanoma risk. And I've identified melanoma patients that have BRCA2 mutations, and that can markedly, well, it obviously increases the risk of breast cancer, but you can then identify female family members that have a higher risk of breast cancer. BRCA2 can affect male breast cancer, so you need to worry about that in the males in the family. But you can't think of just one organ system. You got to think about the other organ systems. CDH1 really is an interesting gene, and that really increased risk of breast, but almost 100% risk of stomach cancer, gastric cancer. So these people undergo prophylactic mastectomies, but also undergo prophylactic gastrectomies. But you think that's pretty radical. But if your risk of developing a gastric cancer is nearly 100%, you save their life by doing a total gastrectomy on those patients. So how do you actually end up managing these pathogenic variant patients or mutation patients? Well, you can send them to a genetic counselor if you have access to that. They're precious commodity. The backlog in Dallas to get an appointment is several weeks to several months. Some places you have a lot of genetic counselors and there's no backlog and you can get right in. So that's sort of a location specific event. The NCCN issues guidelines. These can be very helpful, but for like say BRCA2, they have no recommendation for what to do with the pancreatic cancer risk. Well, I mean, you can get your ovaries out and you can certainly monitor the breasts, or you can do prophylactic mastectomies. Can't do prophylactic pancreatectomies. And I need some guidance for that because it's patients are nervous. I'm nervous as their physician. So what we developed along with, what Kevin Hughes developed at Harvard was a program called Ask to Me, which gives you an age adjusted risk of cancer for each gene. And then on top of that, we layered in something called personalized genetic insights. Again, it was a company called MedNeon. It is a company called MedNeon, and they have a method for this. So don't panic when you get mutation patients. There's plenty of management help. You don't have to not test because you're worried about finding results. Here's what Ask to Me, the website looks like. It's a fantastic resource. I use it every week in my practice. In the middle, you pick the gene. There's I think there's over 30 genes now that are in this program. You put their sex at birth and their age, because it's age adjusted. You put prior surgery. You're not going to get ovarian cancer if you've had your tubes and ovaries out. You put in what other previous cancers they've had. You submit it, and then it'll calculate it up. So this is for a 25-year-old patient with a BRCA1 mutation, high risk of breast cancer, also high risk of ovarian cancer. Those clearly need to be addressed. But also here's this pancreatic cancer risk. It's not high, but it's 7%. So you're looking at what's that, 1 in 14 patients are going to get a pancreatic cancer or get pancreatic cancer. And that's a hard gene to screen for. And it's certainly not anything you can do prophylactic surgery on. So, but we do have recommendations for it. I'll show you in a bit. So here is so that's the Ask to Me. We'll give you age-adjusted risk curves and NCCN management. But the most important thing is on top of that, with the same phone app, this is the left blue is the genetic risk, whether they qualify or not. But on the right is if you have a mutation. In the green box, it will give you management recommendations. NCCN will have categories where they'll say NA, not enough information to help you there. Expert Insights, which was a panel of clinicians, including genetic counselors and surgeons and medical geneticists, developed insights that will give you management recommendations that's beyond the NCCN. genetic testing companies cannot give you anything except for the NCCN. So this is an add-on product, but again, it's by MedNeon, but distributed by Invitae. So be on the lookout from your reps from Invitae for this very, very practical, personalized genetic insight report. I love this, and I use this every day. It's in very clinician friendly, but also patient friendly language. I give it to my patients who have genetic mutations. You know, they're a bit panicked, and when they see that there's a plan for them, they become less panicked. So you need to decide in your practice, when you start doing testing and getting these mutations, are you going to manage the breast portion only, or are you going to manage all the cancer risk? I'm a surgical oncologist by training. So in addition to the breast portion, I actually enjoy managing all their risk. Being the orchestra leader, I don't do like say oophorectomies on patients, but I certainly send them to people that can do a good job with that. Or you just let the genetic counselor handle it, or you just refer it on to the specialist. You know, ATM has a lot of GI organs at risk, pancreas and stomach and colorectal. So you can send it on to the GI gal or guy and let them manage it. So as long as it's still better to identify this, even if you're not managing all their cancer risk. It's better to identify it and get it to the people that can manage that risk. So let me go over just sort of the highlight of the genes that we need to worry about for management. BRCA1 and 2 obviously is the most common in breast cancer. And the biggest decision really isn't bilateral salpingo oophorectomy, except by age. You know, want to get them through their reproductive life. But it's really, do you do prophylactic mastectomies on these patients or not? They certainly carry a high enough risk that I discuss it with them for sure. It varies by age. So you can identify a BRCA2, for example, patient at age 25, high risk over the course of her lifetime, 61%. Or perhaps you're identifying this BRCA2 cancer patient at age 70 because her sister at age 60 developed a breast cancer. Her older sister, who's 70, has a BRCA2 mutation. Her risk is much less. You may not talk to her about prophylactic mastectomies, but you certainly want to talk to her about increasing her surveillance by imaging and physical exam. But what about prophylactic mastectomies? Well, the Netherlands did this very cool study looking at prospectively looking at BRCA1 and 2 mutation patients. They had almost 1,700 BRCA1 and 1,100 BRCA2 patients. About a third in each group chose prophylactic mastectomy, and then they followed them over time. The BRCA1 patients that had a prophylactic mastectomy, their breast cancer specific survival almost 100%. Prevented cancer in almost all those patients, and it was better than if they just surveilled them. So certainly for my BRCA1 patients, I definitely recommend prophylactic mastectomy if they're in an age group where they're carrying a significant risk. BRCA2 is a little different story. Surveilling them has almost the same breast cancer specific survival as doing prophylactic mastectomy. So their tumors are generally lower grade and hormone receptor positive. If they want to be followed, I will follow them. So it gives them a little bit of relief if that's something they want to be followed, or maybe they need some. And all of these are, I guess I should say, these are not emergent decisions. They're not even really urgent decisions. They're decisions that can evolve over months, maybe even a year, and they can change. Maybe a patient at 35 who has a BRCA1 mutation definitely doesn't want prophylactic mastectomies because she wants to breastfeed. She wants to have a child. She has 1 or 2 children. Now she's 45. She may make a different decision and do a prophylactic mastectomy. So these are decisions that can evolve over time. And it needs to be, based a mutual shared decision making with the patient. So the other big 5 in breast cancer, TP53 or P53, the regulator gene in the cell, P10, STK11, CDH1, and PALB2. Here's TP53, super high risk of breast cancer, and they develop it early. The little graph on the right, that's age 40, that arrow. they're already carrying a 35% risk of breast cancer. So once you identify that, you need to start having this discussion with those patients. They have a ton of other cancers, brain cancer, good Lord, osteosarcoma, other sarcomas, adrenal, endometrial, gastric, lung, melanoma. So you don't pick this gene if you get to pick your gene mutation. That's a joke. Obviously, you can't, but this is a bad one. And these patients should probably be managed in a clinic that's doing a lot of this, because they have a lot of risk in a lot of different organ systems. I've seen some recommendations that these patients should get annual whole body MRIs. Think about that. P10, another bad actor for breast, but also for thyroid. Look at that risk. Endometrial. But look when their breast cancer occurred. So they're by age 40, you're approaching 20%. But if they want to have some children before age 40 and breastfeed, you can hold off on their prophylactic mastectomies. The real risk starts after 40. STK11, Putz-Jaeger syndrome. They do have these mucosal pigmented lesions, which is a phenotypic characteristic of that this particular mutation. High risk of breast cancer, up to 40%, but also gastric cancer, colorectal. And again, look at the scale. At age 40, the risk is only about 8%. So if they want to reproduce and breastfeed, they can. Just need to be aware of it. It's another bad actor, though. A lot of different cancers involved with this particular genetic mutation. That's why it's one of the big five. CDH1, breast and gastric. They're starting to get, by age 40, a significant 15% of breast cancer. So maybe earlier in life need prophylactic mastectomies. There is a known risk of colorectal cancer, although we don't know how high that risk is yet. We just don't have enough data. PALB2, it's in that DNA repair group with BRCA1 and 2. Increased risk of breast, pancreatic, and ovarian. But again, their risk of breast cancer occurs later. They can certainly get through reproductive life and breastfeed if they want before you offer them any prophylactic mastectomies. I'm generally offering prophylactic mastectomy if your lifetime risk is 40% or greater. I do like the polygenic risk score. Let's not forget that, because that can modify that. That can bring it down or up. Let's talk about the other, they're minor genes compared to the other big five, but these are very significant genes. ATM, CHEK2, BARD1, NBN, and NF1. So ATM risk about 40%, colon, pancreas, gastric. So these are patients that I consider prophylactic mastectomy on. NBN, the risk is approaching 40%. So this is also a group that you need to start discussing it. Now, if you look where their real risk, it starts taking off in their 50s and 60s. So no hurry for this one. They have other risks, other cancers you also need to be aware of and that need to be managed and screened for. NF1, neurofibromatosis. Obviously, they have malignant peripheral sheath tumors. That's how the gene was discovered. But look at that breast cancer risk in this patient population, almost 40%. Brain tumors, obviously, if you're messing with nerves, you're also messing with the brain. GIST tumors, other tumors. So again, their risk, though, takes off really after mid-40s, really. So no hurry on that, but that is something you certainly need to be aware of. BARD1, their risk really only hits the mid to upper 20s. I don't offer them prophylactic mastectomies, but I surely am screening them by MRI. CHEK2, that's the one we really need to look into the polygenic risk score, because this can vary from, if you don't do that, it's around 23% for the whole group of CHEK2s, but it can go down to 6% or up to 70%. So at 6% or 20%, I'm not offering prophylactic mastectomy. At 40, 50, 60%, I am. You got to worry about their other cancers with colorectal and kidney, ovarian, thyroid. So there's a lot of cancers to screen for and manage in this population. Other genes that increase your risk: BRIP, MUTYH, which was the most common gene in our non-NCCN group in the Universal Registry, and the RAD genes. MUTYH really is a colorectal cancer gene, but it does increase breast cancer risk. So I do some additional imaging on these patients. The BRIP and the RAD groups increase ovarian cancer risk. Very important to note that. They do increase breast cancer risk, but we don't have enough data to give you an estimate on that. So in the last few minutes, let me talk to you about the future, and maybe it's the present. So at Geisinger, which is a healthcare system in Pennsylvania, they offer whole genome sequencing to all their patients. And the PCPs can order it. There's no specific genetic counseling. And then if they have a positive, they see the genetic clinic. And when they've tested over 250,000 of their patients out of 2 million. And interestingly enough, BRCA1 and 2 pathogenic variants or mutations occurred in 0.5%, 1 in 200 unscreened patients that just are getting genetic testing because they're offered it. 1 in 200 have a BRCA1 or 2 mutation. That's amazing. And if you can pick it up when they're 25 and screen them, follow them closely, screen that, and then potentially do prophylactic mastectomies, prophylactic oophorectomies, watch for pancreatic cancer, you're saving their life. And then you cascade test their siblings, their parents, their children, you're saving a lot of lives. So Geisinger has figured it out. There are more of these programs. Kevin Hughes, who developed Ask2Me at Harvard, has now moved to University of South Carolina in Charleston, and he just started a program with a genetic testing company called Helix to do the same thing. So this is happening, and I predict that everyone will have whole genome sequencing by 2030. There are kits available right now where you can get whole exome sequencing. I actually had my whole exome sequenced by Retest 2 years ago. I won't tell you the results, though. So everybody may have it by 2030, but I could be wrong. It could be 2022. And I'm going to leave you with Mary Claire King's quote: "To identify a woman as a carrier, as a mutation carrier, only after she develops cancer is a failure of cancer prevention. We need to move up genetic testing before they get a cancer so that we can prevent their cancer, save lives, save their family member lives. And that's really is the future." So thank you very much. This has been a pleasure to talk to everybody. I hope everybody got a little something out of it. And I think we have time for questions. I don't know if that's part of this, but I'd be happy to take some if needed.
Yes, sir. Thank you very much for your talk. It was extremely interesting. And we have some time for questions. And I have a question from the audience. They ask, would you change your criteria for evaluation in a patient with a VUS in a gene that most predictive models classify as pathogenic? But there is no information about this population or population-based in a patient from a poorly represented population or minority in those that the molecular tests are performed?
Yeah, that is an excellent question. The quick answer is, for VUSs, you do not treat them as a pathogenic variant, period. That said, we do not have very good variant adjudication in other ancestry groups. That is improving, but it is still not very well done by many labs. Most of the labs have gotten together and donate all their data to a big database called ClinVar, where these adjudication events can occur. More and more patients of other non-European, non-white ancestry are being put into that registry. We are gathering more data on non-white ancestries. So we will hopefully adjudicate those. I think still, though, most of the VUSs, you have to remember, end up being benign. So certainly, even if it's in a bad gene, even if it's in BRCA1 or 2, a VUS there, even if it's in a non-white ancestry, do not treat those as a pathogenic variant. Now, would I increase my surveillance? Yeah, maybe. Certainly physical exam, and maybe depending on what their mammogram showed, if they had dense breasts, I would probably try to include some advanced imaging with either a nuclear medicine scan of the breast, a sestamibi scan, or an MRI. Not everybody can do an MRI. I'm claustrophobic. I know a lot of women are. So I at the moment, don't do anything radical like prophylactic mastectomies. Maybe increase their surveillance. There's not good data on it yet, but it makes some common sense to do that in non-white ancestry, because the VUS adjudication is just not as good as it is in other populations. Great question.
And you talked about this polygenic risks score. You talked a lot about it. Is it used in the clinical setting regularly, or just for clinical trials, or what would be your recommendation for that?
Yeah, so it is offered by Myriad right now. So you, if you get a genetic test by Myriad, you're going to get the polygenic risk score. They'll look at their gene panel, which I think is around 30 genes, and so you get those genes. If you have a mutation, they'll adjust it by the polygenic risk score that they'll do. If you don't have a genetic mutation, they'll give you your tyracustic risk modified by their polygenic risk score. So it is clinically available. I would say it is not in widespread use, but it is definitely in use outside of clinical trials. So I like it. I think all the genetic testing companies realize what a good product that is, and they're all moving to develop a polygenic risk score of their own. Probably the most important thing, though, is ultimately going to be adjusting that for ancestry. So right now, the polygenic risk score is really white European women based, and it will be broadened. And it is. I know Myriad is working on that right now. They're getting close to putting out other ancestries, and I'm sure all the other genetic testing companies are doing it. You have to start adjusting for these things by ancestry.
So eventually, it's going to be routine to use this risk
correct.
score.
The polygenic risk score. I don't know if Myriad bought this company, but the polygenic risk score was around for 10 years. It was based on something called a genome-wide association study, GWAS, and they found these 86 genes were significant for predicting risk of breast cancer in women. So that there was a company that commercialized that called Prevagen. Well, the company was called Phenogen. They were out of Australia. Their test was called Prevagen. That company, it never really had good uptake, but I think they could come back today, and I would order it. I like polygenic risk score. About 2/3 of my patients are non-white Europeans, so it doesn't help in all my patients, but and hopefully those other ancestries will be available soon. But I love polygenic risk score. It's going to be the wave of the future. It's kind of here now, but it's going to blow up shortly.
Another question from the audience is, how well represented is the Hispanic population in the Ask2Me tool?
Yeah, not very well. It is represented, but not very well. Again, those risk curves are going to get adjusted by ancestry. There is data coming out all the time. Those risk curves are built on papers that studies that are done and published. There are more and more papers coming out in other ancestries. So those curves will be ultimately adjusted. And one of the questions that they're going to ask you on the front end is not just age, and sex at birth, but it'll be ancestry. I think ultimately ancestry is going to be determined by genetic testing. We're all a bit of a gamish of ancestries. We're not one pure ancestry. So I think the ancestry will be sorted out by genetic testing, and we'll get a polygenic ancestry score, and that will modify those risk curves. But at the moment, it's the best we have. So it's certainly not perfect. It's not perfect in other ancestries, and but it's better than nothing, I guess, at the moment. And it's certainly, everybody knows those need to be altered by ancestry, and they're working on it.
Enrique?
Yeah, thank you, Peter. And maybe a naive question, but how to choose a brand, how to choose, how many genes should we choose? So it's for the brand, or it's for many ones, or for the commodities? I mean, how to choose
which company should you pick? Well, I would say they're all excellent. There's not a quality issue across any of the testing companies, the big ones. The big ones being Myriad, Invitae, Ambry, GeneDx, Natera. I think Quest has a panel. There's a lot of different companies that have panels. So I think if you pick a big company, quality is not an issue. Then it's kind of how many genes do you want? The price is not by gene, it's by panel. So I always pick the biggest panel. So whatever company I choose, there are subtle differences between companies. Myriad has the polygenic risk score. I love that. I think that's great. That's a good choice. But their panel size is 30. If you're worried about other peripheral genes, then maybe you need a bigger panel. Ambry has a way to do adjudication of VUSs by RNA analysis. I think Invitae may have that now, and I think Myriad has some level of that. So if you're worried about VUS adjudication, you want as low a VUS rate as possible, then maybe you pick Ambry. All companies have subtle differences with that. At the end of the day, I try to pick the biggest panel, or I have patients that don't meet qualifications. Their insurance isn't going to pay for it, and they're looking for a cash price. $250 is very reasonable. It's about a mani-pedi in Dallas, and that's the Invitae price. I think Ambry has matched that price. It may be $295. I don't know about GeneDx or Natera, but I think all those companies work with you. But so some of it is cost. It's really panel size and then the subtle differences between the companies. If you want PRS, which I think is great, then go with Myriad. They're the only ones that have it right now.
Okay. And a very last question, when to retest a patient? I mean, some of patients have been tested like 10 years ago or maybe around that. Yeah. Now it's a new generation and another BUS, and what patient that has been tested and was negative, even with or without an BUS, when to retest that patient?
Yep. That is another fantastic question. And the biggest thing there is 10 years ago, we were testing for 2 genes, maybe PAL-B2, maybe 3 genes. So if they say, oh, I've already been genetically tested and I'm negative, absolutely retest those with a bigger panel, because there's at least 30 genes that are associated with breast cancer. And the more we test, the more we realize there's probably more genes associated with it. So if they've had a small panel, 2 genes, BRCA1 and 2, or 3 or 4, maybe, or if they picked a 5 gene panel 7 years ago, I would absolutely get a bigger panel. We're ultimately moving to whole exome sequencing. We're going to be doing all their genes. So we're going to be looking at cancer genes, cardiac genes, neuro genes, psych genes, pharmacogenomic genes, how you metabolize drugs. So, when the price of whole exome sequencing falls, and we get some management tools based around the results, I think we're going to be doing whole exome sequencing, and that's the future. But to answer your specific question, if you had a small panel, I would retest them now with a bigger panel. Absolutely. That's very important, actually. Let me just put in I actually like entertainment genetics, which is 23andMe, but I've had patients come in and say, oh, I had 23andMe and I'm gene negative. Well, they test for 3 different point mutations in BRCA1 and 2. They don't even test the whole gene. The gene BRCA1 is 1,800 base pairs long. So they only test for 3-point mutations in BRCA1 and 2 combined. So if you've had 23andMe, that's not real genetic testing, right? So that's also something that's happening. They need a real genetic test with a big panel, in my opinion. So thank you so much.
Thank you very much for your talk, Peter. It was great. It was very encouraging for our residents and the rest of the audience. I would like to thank you for participating with us this day. And Enrique?
Yeah, thank you, Peter. And hopefully we have you in another time this masterclass we have it each year. Along of the year, it's for our residents. So I know that you have a lot of insights in other fields, and you're an excellent friend, of course, but an excellent speaker and an excellent physician. And one of the greatest phrases that I have heard you is, "You are leaders, no followers." And so to encourage our fellows and our residents on that, I think it's seeing you, what have you been done.
Well, thank you for those very kind words, and I really enjoyed talking today, and the questions were fantastic, very insightful. So be happy to do it again. I'm going to run off to the OR. Take care.
Hasta luego, muchas gracias. Gracias a todos por participar el día de hoy. A nuestra audiencia los esperamos en la próxima Masterclass.
Gracias.
Gracias, Henry.
Gracias a ti. Bien, ¿no?